Hello, everyone, and welcome. My name is Bobby Frederickson, and I'm the Senior Growth Lead here at Patient Ping. I'm thrilled to welcome you all to our New Hampshire webinar on the CMS Interoperability and Patient Access Rule, e-Notifications Condition of Participation. As you likely know, CMS published the rule to the Federal Register on May 1st, 2020, and hospitals have 12 months from that day to comply with the new e-Notifications Condition of Participation. Thank you all for taking the time to join us and learn more. Before we dive into today's conversation, I'll just be covering a few technical logistics. First, attendees will remain muted throughout the webinar. We will have a Q&A portion at the end where you will be encouraged to submit any questions via the GoToWebinar control panel by clicking the question mark icon on the right-hand side of the screen, and you can feel free to do so throughout the presentation. We will try to answer as many questions as possible, but if we can't get to all of them, we will follow up with those of you whose questions were missed. Lastly, a copy of the webinar recording will be sent to all registrants shortly after the session, as well as a copy of the presentation slide decks. So with that, I'm very pleased to introduce our speakers for today. First is Vanessa Kuhn. Vanessa is Patient Ping's Director of Policy, and she possesses close to 15 years of experience in both the public and private healthcare sectors. Prior to Patient Ping, Vanessa was a program officer at the CMS Innovation Center for the Pioneer ACO model, and subsequently served as the Director of the LifeBridge Physician Network in Maryland. She was also Chief of Performance Improvement at Behavioral Health Systems Baltimore. Vanessa earned her PhD from Johns Hopkins University in Health Policy and Management. Next, I'd like to introduce you to Cyprian Kabuka. Cyprian is Patient Ping's New England Director of Strategic Accounts, where Cyprian manages health system relationships across Patient Ping's most dense and engaged network of providers. Prior to Patient Ping, Cyprian co-founded a healthcare technology company out of New York called Rubicon MD. They provided on-demand access to specialist expertise through primary care e-consults. Cyprian is completing his master's in health informatics and analytics at Northwestern University. So we're very excited to have you all here today, and Vanessa, I'll go ahead and turn things over to you.
Great, thank you so much, Bobby, for the kind introduction, and I'm really excited to get us started today and to have so many of you join our webinar this afternoon. I know we're extremely busy, so we certainly want to make sure that this hour is valuable and give you all the information you need so you can understand the new hospital condition of participation, or the COP, that CMS recently finalized in much more detail. So with that in mind, our goals for today are to set up the context for the CMS Interoperability and Patient Access Rule, and dive into the details of the new e-notification COP requirements. I'll also highlight the key considerations you need to take into account to make important assessments and decisions about your readiness to meet these requirements. We'll also touch on the impact of the COP on post-acute providers. And then my colleague Cyprian will provide additional details about how you can comply with the COP using Patient Ping's route solution. And as Bobby already mentioned, we'll end the session with time for Q&A, so please, again, feel free to add those into the chat box. All right, next slide, please. So to provide context, in March, as Bobby already alluded to, there were two significant and really complementary health IT rules that were finalized that you've probably heard about. The first one is the ONC info blocking rule, and the second is the CMS Interoperability and Patient Access Rule. Really both focus on improving information sharing, making data more accessible to patients, and ensuring that data can be readily exchanged to improve patient care and outcomes. And today, during our discussion, we'll focus on the CMS rule. That rule contains multiple final provisions, and one of them, Section 10 in particular, is the e-notifications condition of participation, which again is the focus for today. Many of you know, especially if you work in compliance, that conditions of participation are the most significant and consequential regulatory lever that CMS has, as those COPs really determine a hospital's certification status and its ability to receive CMS payments. COPs are those requirements that get audited by state survey agencies and accreditation organizations. And if you're not complying with all COPs, it can jeopardize your standing with CMS and your Medicare provider agreement and status thereof. So it'll be really important to meet and comply with these requirements. As mentioned earlier, CMS published a final rule on May 1st in the Federal Register and included a 12-month implementation timeline. So again, it'll really be all in effect by May 1st, 2021. Next slide, please. I want to first spend a minute on the intent of the rule, as it's important for context and really understanding the requirements. While some information sharing is, of course, already happening, occurring across different regions and different localities, CMS drafted the COP as a way to accelerate that information sharing, really with the intent of improving patient outcomes and to give non-hospital providers access to needed information about their patients. And as stated in the final rule, CMS recognizes that hospitals are critical to the seamless care transitions and that more information enables better care coordination and better outcomes. And with the new COP, really CMS hopes to support information sharing across the entire care continuum, also ensuring that information is available to providers for treatment, care coordination, and quality improvement activities, and to eliminate any remaining or existing barriers to information sharing. Again, the takeaway here is that CMS created the COP to improve cross-continuum coordination and to help eliminate any barriers for information sharing. Next slide, please. So let's now jump into the actual COP and the specific requirements. At a high level, the requirements are as follows. Hospitals must make a reasonable effort to send admission, discharge, transfer, or ADT notifications to post-acute providers, primary care practitioners, practice groups, and entities that need the information for treatment, care coordination, or quality improvement activities. And again, compliance is May 1st, 2021, and over the next several slides, we'll dive into much more of the details of the requirements. Next slide, please. So let's take a more detailed look here with this slide. As the basic level, the requirements are that e-notifications need to be sent by hospitals, psychiatric hospitals, and critical access hospitals, and must be sent at the point of inpatient admission, discharge, and transfer, and at the point of ED presentation and discharge. And they must be sent to the patient's established primary care practitioners, those primary care practice groups and entities, post-acute providers and suppliers, as well as any other practitioners or groups or entities that are primarily responsible for the patient's care. And then finally, as part of the requirements, the messages or notifications must contain, at minimum, the patient name, treating practitioner name, and sending institution name. Next slide, please. So I'll go ahead and kind of take each of these components and talk a little bit in more detail about those specific requirements. First, let's talk about who is actually required to comply. We saw on the last slide that it's hospitals, psychiatric hospitals, and critical access hospitals. Now, of those, really, it's those hospitals that use EMRs or other electronic administrative systems that have the capacity for notifications that are conformant to the HL7 2.5.1 standard. So only those that meet those specific requirements will fall within the COP. However, I should note that pretty much every EMR has that capability, so most hospitals will be included under the COP. We noted in the slide the specific code of federal regulation subsections for each hospital type where the new COP will be inserted. They'll be part of the medical or the clinical record requirements. Next slide, please. So now that we understand what hospitals are subject to the new COP, let's talk more about the actual notifications. As mentioned, notifications must be sent at the point of inpatient admission, discharge, and transfer, and at ED presentation and discharge. The ED requirement was really newly added as part of the final rule based on the responses and the feedback that CMS received on the proposed rule. And notifications about internal hospital floor or unit transfers are really not included or required under this COP, but certainly are allowed to be sent if that's a possibility or is part of the HL7 feed. Notifications about other event types and sort of what that looks like in terms of where those notifications go, we'll talk about on the next slide. But important just to note here that the notifications can either be sent directly or through an intermediary, so that would be a third-party intermediary. And then second, notifications have to be sent in real time. So per the final rule language, notifications must be sent, and I quote, at the time of the patient's registration in the hospital emergency department or the patient's admission, et cetera. So that really indicates kind of the real-time nature of the notification requirement. So again, really at the time of the event occurring is when those notifications have to be sent to the other providers in the community. Also, the message must include at minimum the patient name, the treating practitioner name, and the sending institution name, as we already reviewed. Really with that, and CMS noted that in the final rule, they're setting the floor or the minimum requirements here. CMS had proposed initially to also make diagnosis information a requirement, but that is now optional and no longer really a required data element. Of course, as long as it's permissible by applicable laws and regulations, it's certainly helpful to have that information included for better care coordination and care transitions. In general, I should just note real quick that CMS makes clear that the e-notifications requirement will apply where permissible under federal and state law and regulations and as consistent with patients' privacy preferences. And then finally, there is no specific format of how notifications need to be delivered. So that's really left up to the hospital or to the intermediary. So no specific requirements there. So the takeaway here just about the notifications themselves is that they must be sent in real time at the point of inpatient admission, discharge, or transfer, as well as at the ED presentation and discharge, and can be sent either by the hospital directly or through an intermediary. Next slide, please. So we talked about which hospitals have to send notifications and what those notifications must include. Now let's turn to the actual recipients of those notifications. CMS specified in the rule that the first category of recipients is the established primary care practitioner, practice group, or entities. So these can be, for example, PCPs, primary care physician practices, FQHCs, and entities like ACOs, where those primary care practitioners have driven those primary care patient assignments and have specifically delegated care coordination activities to the entity. The second category is practitioners, practice groups, or entities that the patient identifies as primarily providing his or her care. So this is something the patient can specify at the point of care, for example, during registration. And those recipients could, again, be PCPs, specialists, community-based clinics, mental health clinics, multi-specialty groups, and many others. And then finally, the third category is applicable post-acute providers and suppliers that transfer patients either to the hospitals and those that receive patients upon hospital discharge. Again, they can be skilled nursing facilities, home health agencies, or other post-acute providers. CMS also further clarified that recipients are those providers with established care relationships that need notifications for treatment, care coordination, or quality improvement activities. Next slide, please. So what does this new requirement really mean for post-acute specifically? It's really the ability to get more information for improved care coordination and transitions of care. So as part of this requirement, providers, in particular post-acutes, but also other community-based providers, can receive those notifications to support treatment, care coordination activities. As we've talked about, that's really the main goal and purpose of the rule itself. It really helps to initiate timely transitions of care, help reduce readmissions and improve outcomes, streamline internal workflows, enhance care transition planning, and then support utilization and total cost of care management efforts across the providers and across the continuum. Next slide, please. We talked about really what hospitals are impacted and the details about the notifications themselves as well as the recipients. So let's address just one other point that I mentioned several slides ago, namely that CMS specified that hospitals have to make a reasonable effort to send these notifications. So while the interpretive guidelines are still being drafted, we can use CMS's responses to the comments in the rule, the finalized requirements, as well as the intent of the rule to define reasonable effort more clearly. So at a basic level, reasonable effort means that hospitals will need to demonstrate meeting the minimum requirements. That means sending all required notification types in real time to the providers with those established care relationships that need the information for those specified purposes that we just discussed. Knowing who those recipients are is really something the hospital or its intermediary will need to determine. Some practitioners may be identified at the point of care by the patients, as we talked about. However, hospitals also have to send notifications to the other providers that fall into the recipient categories, as we saw in the last slide. So those post-acute providers and other practice groups or entities with those established relationships that may not necessarily be named by the patient at the point of care. And those recipients, again, may not be determined so through that communication with the patient, but still need and are eligible to receive notifications for established patients. Some of those, if you think about some of those recipients, may be located across state lines or in different geographic areas, given that many patients seek care at specialized tertiary hospitals outside their immediate community or might reside in different states over the span of a year. For example, if you think about Medicare snowbirds that have different providers in each location. So to determine those care relationships and recipients, then hospitals, either directly or through the intermediary, need to implement policies and procedures that they then have to demonstrate through the audit process that can respond to notification requests from those providers made on behalf of their patients. In that way, hospitals can demonstrate that notifications are really sent to all of the intended and minimum required set of recipients in the rule and can check the box. Of course, it's reasonable for hospitals to forego delivery of notifications to recipients that don't want to receive notifications or that don't have the capability to receive them, or where there's just not enough information available to establish the identification of the recipient. And CMS is very explicit in that, in those exceptions, but it doesn't necessarily mean that those policies and procedures don't have to be in place. But those would be the exceptions. On the flip side then, the following would really not be deemed as reasonable effort. So first, failing to put processes and systems in place to meet the basic notification sending requirements to meet the needs of those recipients. And then second, systematically excluding a subset of the specified recipients. For example, never having sent notifications to post-acute and not having that ability to do so. And then third, long or indefinite delays of notification response is also not part of the reasonable effort requirement, as CMS is deliberate in the real-time notification aspect of the notifications. And so to summarize then, hospitals really have to meet the basic requirements outlined in the rule to demonstrate through their policies, processes, and systems that they have put in place that notifications are sent to the designated recipients that are eligible and that need that notification for those treatment, care coordination, or quality improvement activities. Next slide, please. And to meet all of those requirements and to demonstrate reasonable effort, which we just talked about, there are really two foundational capabilities that have to be demonstrated. The first is that hospitals need to be able to send patient-identified notifications to individual providers. That means PCP, other patient-identified practitioners, as we talked about. And the second, hospitals have to be able to respond to requests from post-acutes and primary care groups for notifications on behalf of the patients with whom they have an established care relationship. So let's just dive quickly into those two capabilities. Next slide, please. So the first one is the patient-identified notifications. Again, really it just requires a process where patients can name or identify their providers, which is something you probably already have in place as part of your registration process within the hospital or the ED. Now, sending those notifications to PCPs and other patient-identified practitioners requires access to a directory of providers' digital contact information, as well as a mechanism to push direct notifications to correctly match providers in real time. So having that ability to send notifications to the patient's identified provider is what you'll need from just a capability standpoint to meet that element of compliance. Next slide, please. And then for the second capability, hospitals need the ability to respond to notification requests from many different types of community providers, as we have shown here in the graphic. So this can involve just a few complexities here, really centered around exercising and executing data share agreements, processing diverse roster types or patient panels or census lists, and managing frequent and real-time changes as provider-patient relationships can, of course, often change, especially in the post-acute landscape. So again, the takeaway here is that hospitals or their intermediary need ways to manage and respond to the many different provider requests, which often proves to be a pretty complex process. And next slide, please. So to bring all of the requirements and capabilities together and to be ready for the surveys that you'll have to respond to for hospital compliance, I just want to spend a quick minute on the process itself. So we know from the final rule that the e-notification requirements will be part of the medical records services COP for hospitals and for psychiatric hospitals, and the clinical records COP for critical access hospitals. So based on the procedures outlined in the State Operations Manual for the Medical Records Services COP, that survey will include two main components. The first is a review of the organizational structure and policies, as well as an interview, and then the second is a records review. For the policies, hospitals need documentation that explains how hospitals meet the notification requirements and what the procedures are to do so. And then for the records review, you'll need to be able to just show through something like an auditing report that notifications have been sent to the specified recipients for those randomly selected patients under review. As I'm sure you're probably aware, hospitals will need to address any deficiencies within the timeline that is specified in the CMS termination procedures. That means 10 calendar days to submit a corrective action plan. So the ability really for rapid remediation will be essential should you not meet those compliance standards. And next slide, please. So this really wraps up the requirements. And to bring it all together, I just wanted to review some of the critical considerations you'll need to keep in mind as you determine how your hospital will meet the new COP. In particular, as you evaluate different solutions or consider whether you want to build this yourself, you should ask how the solution or how the tools that you build will meet these 8 points. So I'll walk very briefly through those. First, consider how you'll identify and then send notifications to those post-acute providers that refer patients to you, that, for example, a home health agency that has a patient on service. How do you notify that when the patient comes to the hospital? And then also, how will you send those notifications to providers that may not really be located within your immediate region? So cross-regional providers with established care relationships that also need notifications for their established patients. Make sure you have considered how you'll be able to fulfill those requirements in terms of notification. You should consider how you'll manage and ensure you have the appropriate data share rights, security, and trust in place between you and the notification recipients. You should also assess how you'll ensure that notifications are actually sent in real time and not unreasonably delayed or batched. And then we talked about this quite a bit, but consider how you'll manage and fulfill continuous provider-patient relationship changes and manage the many endpoints to where notifications need to go. And what we just talked about, what will you use to demonstrate compliance once you actually do get surveyed? What really will help you get that peace of mind and be able to demonstrate that you're fully compliant? And something we haven't actually talked about, but it's important to consider, is really how will you ensure that community-based providers, those notification recipients really, that need and want notifications from your hospitals, that they have an optimal and excellent experience as well in that process. I mean, you certainly rely on those providers for referrals. You send your patients to them for ongoing care, and you want your brand to lead in the market and be just a good partner to those other providers. So those cross-continuum partnerships and provider relationships are critical for patients' experience and their care. So making sure the COP actually helps the overall information sharing effort and making sure that other providers have a positive experience in all of this will be important and can set your hospital up for success and a great community partnerships. And then finally, of course, you need to consider how you'll meet the compliance deadline, which is the May 1st, 2021 date. And with those considerations in mind, I'll now hand it over to my colleague Cyprian, who will give additional information about patient paying and our solution route. So Cyprian, please take it away.
Thanks, Vanessa, and hello, everyone. So as we've just outlined, hospitals will need to weigh a lot of considerations when determining their strategy for how they'll comply with the e-notifications conditions of participation. Hospitals will have to weigh whether they want to build the required compliance infrastructure in-house or to partner with a third-party intermediary to outsource compliance. For those hospitals that choose to outsource compliance to an intermediary, it will be important for those hospitals to feel confident that their intermediary will enable full rule compliance by May 2021. Here at Patient Ping, we feel uniquely suited for hospitals' compliance vendor of choice. And so that starts with our network. We have the most robust national ADT network across the care continuum, comprised of over 1,000 acute facilities and over 5,000 post-acute facilities that contribute their ADT data to our network to enable e-notifications to be sent to their care providers. Our network consists of vast amounts of both post-acute partners and primary care groups who not only contribute data to the network, but also rely on Patient Ping to receive notifications for their patients. Both of these groups are required recipients for notifications under the conditions of participation. We cover a large patient population with over 43 million patients on our network nationally and over 135 million patient ADT events processed over our company's 7-year history. In addition to our network, there are a couple of key considerations that make our business the preferred vendor of choice for this e-notification COP compliance. One, we have a superior patient matching algorithm with over 99.99 match rate certified by ONC to make sure patient data is sent to the right providers who have established care relationships with patients seen at a given hospital. Two, we have a scalable process that can handle the required volume of real-time e-notifications that will need to be sent across the country in accordance with these conditions of participation. And then three, we have a streamlined onboarding process with no software to install or upgrades necessary. So implementation requires a few hours of time from a hospital's internal IT team. In summary, Patient Ping is a clear choice for the conditions of participation compliance vendor due to our robust network and our complementary, scalable, and streamlined process. Next slide. So we just talked a lot about the strength of our national ADT network, but what about the mechanism to ensure that Patient Ping will help you achieve compliance? This introduces Patient Ping Route, a single solution that guarantees e-notification COP compliance. There are four main components of Route. We send notifications we send the required notifications to patients, PCPs, or other patient-identified providers via our direct messaging service. Two, we capture and fulfill requests for notifications from community providers, both within and outside of our current national network. So for hospitals, sending us your ADT data will immediately achieve compliance for the largest aggregation of valid community provider requesters in the country. So over 1,500 post-acute providers and primary care groups who rely on Patient Ping to receive notifications today. For community providers and post-acutes outside of our network, we offer a convenient requester portal where Patient Ping will validate and manage all incoming requests for notifications. In addition to our full audit trail of e-notifications sent for security and CMS survey peace of mind, finally, we offer an optional outbound ADT data feed management to HIEs and other intermediaries to reduce your organization's IT burden so that you only have to maintain one outbound ADT feed to Patient Ping. Over the next few slides, we'll dive a bit deeper into each one of these components for our route solution. Next slide. So for the required real-time notifications that must be sent to patients' PCPs or other patient-identified providers, they're sent via a direct messaging component of Route. So PCPs and other providers deemed necessary or responsible for patients' care are identified in the patient record during a hospital encounter. Once that data is included in the ADT to Patient Ping, we look up that provider or other provider's NPI, as well as other identifying information in our proprietary directory, as well as other patient or partner directories, and then return that provider's direct message address. Once the direct message address is matched, then notifications will be sent in real time to the identified PCPs or other providers. PCPs or other providers can opt out of receiving direct messages if they simply do not want notifications or if they wish to consume notifications in a different manner. Next slide. So moving on to the community provider organization request, capture, and fulfillment. For hospitals, simply contributing their ADT data to the Patient Ping network will allow them to satisfy compliance for the largest collection of community provider e-notification requesters in the country. With over 1,500 community providers representing over 11 million patients, Patient Ping is able to receive notifications on this volume every single day. Simply contributing ADT data to Patient Ping will achieve compliance for hospitals for the largest chunk of required community providers under COP. Next slide. We recognize that hospitals may partner or treat patients affiliated with community providers who are not currently on our national network. So for this, we offer a requester portal. The requester portal is a digital asset that can be embedded into your public or private facing websites. Patient Ping will validate all inbound requests and manage the complexities associated with signing up data sharing agreements, provider requested processing, all to enable real-time notifications to be sent. Community providers who make requests via the portal have a few options for how they'll receive those notifications. They can choose to receive notifications directly from the hospitals. They can choose to upgrade to our industry-leading Pings product to receive notifications when their patients receive care at a hospital or at one of the 1,000+ hospitals and post-acutes already on the Patient Ping national network. Hospitals can provide additional value back to community providers with Route by offering flexible e-notification delivery options to suit that community provider's workflows. Community providers can receive notifications for their patients who receive events at the hospital via a web app, SMS, email alerts, and direct HL7 integration with their EHR, Pop Health software, or another application. And then lastly, they can also receive notifications via direct download. Next slide. For auditing, Route includes a full audit trail of all e-notifications sent. Our audit report can be used by your internal teams during the CMS surveys for random patient record reviews. Patients chosen for random record review can be looked up in a detailed audit log dashboard by their unique identifier to prove e-notifications were sent in real time and by what method. The summary dashboard provides an at-a-glance view of data sharing with community providers at a national level. And this can also be used to surface community providers who may want to foster closer relationships with that hospital. To further support you during the CMS surveys, Route includes policies and procedures documentation guidebook that's included in our package. Next slide. So for CMS surveys for the e-notification conditions of participation rule, CMS, the survey teams must review your hospital's documentation compliance policies and procedures. Route includes written policies, procedures, guidebook for use in demonstrating your compliance with these surveys. During the Route implementation process, Patient Ping will work with your staff to ensure that everyone is sufficiently trained, not only on the functionality, but also on that guidebook content in service of demonstrating compliance with this conditions of participation. Next slide. The last component of Route is our ability to route ADT data to HIEs and other intermediaries with an optional, sort of an optional feature that we offer as part of this solution. So with Route, Patient Ping will send data to any desired entity and HIE, other intermediary, on your behalf, reducing your organization's IT burden so that you only have to maintain one outbound ADT feed to Patient Ping instead of multiple feeds to multiple recipients. Next slide. So in summary, those were the components of Route, but this brings us to the compliance guarantee. We're confident that with Route, hospitals will be compliant not only with the e-notification conditions of participation, but we also back that up with a compliance guarantee. So as Vanessa had mentioned earlier, if any Route customer is ever found to have a deficiency with regards to compliance during that CMS survey process, We will deploy patient ping experts on site where permissible, and will help resolve that issue and develop the required corrective plan within the 10 calendar days at no cost. That's how we support the acute side of the equation. And again, as we had mentioned earlier, from a community provider requested perspective, we're offering a convenient solution that helps you build better relationships with your partners as they request data and interact with your system. Next slide. We've talked a lot about sort of the tools, the functionality, the guidebook that we offer you to help satisfy compliance. But when we think about why patient ping, the difference, we've got a robust network. We have a strong product, but we also have world-class leadership with relevant experience across CMS, Commonwealth, Epic, and Cerner. This really is the bedrock of why we're uniquely positioned to execute on this. We, for the last 7 years, have been providing care management solutions to facilitate better transitions of care, and this rule helps facilitate the sharing of data to that mission and to that end. So we're excited about what we have to offer you. We've been looking forward to this for quite some time, and hopefully you decide to partner with Patient Ping if you're an acute facility, and hopefully we get to work with you if you're a community provider. So that concludes the product section of this presentation. I'll go ahead and hand it over to Bobby, and we can take some questions with the remaining time.
Great. Thanks so much, Cyprian, and thank you, Vanessa. We have had some questions submitted over the course of the conversation. Again, we will try to get to all of them before the end of the session, but if there are any that are missed, our team will go ahead and follow up with you directly via email. While we're going through these questions, I'd also like to point out some additional resources for everybody's reference. To learn more about the new rule, you can visit us at www.adtnotifications.com or contact Patient Ping at connect@patientping.com. For more information on Route, our compliance solution, you can visit us at www.patientping.com/route. And we have also linked several helpful assets for you in the appendix of this presentation, which will be shared after the webinar concludes. So let's go ahead and begin with the questions. So the first question that came through pertains to who is eligible or who is subject to the COP requirement. The question is, are LTACs and inpatient rehab facilities covered under the COP?
Bobby, I can take that one. Yeah, that's a great question. CMS does include LTACs and inpatient rehab facilities under the definition of hospital for this requirement. So yes, they will also be required to meet the new COP requirements. In addition, just in terms of other hospitals, specialty cancer hospitals, children's hospitals would also be part of this requirement. So those would all be in addition to just your standard acute care hospitals. Good question, though.
Great, thank you, Vanessa. And the second question I may direct towards you as well, which is, do you have to get consent from patients on sharing their information?
Yeah, I'm happy to take that one too. So the short answer really is no. So HIPAA's treatment, payment, and healthcare operations exception, or the PTO exception as you may know it as, really allows that information to be shared without consent. So, of course, again, CMS stated within the rule that patients' privacy preferences need to be followed, and that any applicable state laws also need to be followed. But other than that, there's no specific consent requirements for the information sharing through the COP requirement.
Great, thank you. This question may be directed towards Cyprian. The question was, what is the obligation to notify a provider if a patient doesn't reveal or doesn't have a PCP that they've indicated at the point of admission?
Thanks, Bobby. So in the event no provider is identified, CMS explicitly states that the e-notification, that the hospital would not be expected to send a notification for that patient. So where we have a PCP or provider identified, we will go ahead and execute the delivery of the notification in that instance. But if a patient chooses not to or does not identify a provider, then the rule is effectively satisfied.
Great, thank you. When should hospitals begin vetting different solutions in order to realistically meet the compliance deadline?
Yep, happy to take that one. So again, the compliance deadline being May of 2021. At Patient Ping, we guarantee compliance, but naturally, with the volume of hospital requests we're receiving and project to receive, I think the right idea is to start looking into your current ability to field community requests today. So how do you field community requests? What volumes do you anticipate based on your patient population? Once that internal assessment is done, then you can feel confident, better understanding whether the patient identified requests could be managed by your EHR. Do you intend to use multiple intermediaries? Obviously, with Patient Ping, we've got a one-stop solution that is an end-to-end compliance tool, and we guarantee compliance. I think the first step, and we've got some tools to provide you, but the first step is to really take an inventory of your current capacity and how best you would execute in May 2021. And we've got some compliance checklist tools that we can provide you. Happy to jump on the phone with any of you, whether you're in the community or an acute facility, and sort of walk you through that checklist and how best you'd be able to satisfy the components of the rule. But I think the right time is to start looking now. And obviously, Patient Ping would prefer at least 3 months before the deadline to make sure that you have some process in place, whether you're doing that in-house or working with Patient Ping.
Great, thank you very much. And it looks like we do have just one more question, unless there are others that come through. But the question was, as a community provider, as a primary care practitioner, what are my options for getting connected to this information and taking advantage of the information that's become available to me under this rule?
Sorry, I may have been on mute. This is Cyprian. So the questions are, as I understood it, if you're a community provider, what are your options for receiving this information? Is that the question?
Yeah,
Bobby?
absolutely. So I think the question, as I'm interpreting it, is, how can community providers get connected to this information? I think the content here has focused quite a bit on how hospitals, what's required of hospitals and how they can comply, but how can a community provider take advantage of this rule to improve coordination of patient care?
Absolutely. So I think there's a multi-pronged approach. First, identify where your patients are receiving care. So that list of acute facilities where you'd like to make the request of that data and engage those hospitals. And then internally start to determine how best to receive that information. If these are real-time real-time notifications, you want them to also be actionable. And so we offer a no-cost solution for providers to receive these real-time notifications. We also offer, a for-cost solution. I think previously, when I was reviewing the requester portal, we can provide those notifications via our web app, SMS, email alerts, direct HL7 integration into your EHR or your Pop Health tool, care coordination tool, or direct download. I think ultimately, internally, getting a better sense, where are your patients going? Which hospitals do you need to establish some sort of connection, and how best do you want to receive that information so that it is actionable? Does your EHR have the ability to receive this information, or your care management tool? Those are the questions that you want to start asking. And again, we're happy to jump on the phone with any one of you and sort of start to map out what your options look like.
That's great. Well, thank you so much, Cyprian, and thanks, Vanessa, for taking the time to walk us through this content today. And thank you so much, everyone, for joining our webinar today. We really do appreciate everyone taking the time to attend. And as a reminder, our team will be following up with the recording and the slides from today's session. So thank you all, and have a great day.